Hello, and welcome to our second online seminar for National Myeloma Month and our theme, Multiple Faces of Myeloma. My name is Deborah Thompson and I'm a myeloma support nurse in Tasmania. I would like to begin this national meeting by acknowledging the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and culture. Hobart, where I am speaking from, is the land of the Myeloma people. We pay our respects to their elders past, present and emerging. We have some great presenters for you today. Helping to chair sessions is Narelle in Perth, and assisting behind the scenes is Laura, two of our lovely myeloma support nurses. Laura is available for any queries or technical issues and can be contacted on our national support line number 1800 693 566. This seminar is being recorded and will be available on our website to view later. We welcome your questions throughout the seminar, which you can submit through the live Q&A box, which you will find if you scroll down the web page. You can also bring out the live chat function by tapping the three dots in the top right corner. Although we'll do our best to answer your questions today, if we aren't able to, we will get back to you by return email as soon as possible, so be sure to add your email address. Otherwise, you can email directly to nurses@myeloma.org.au. Just below the live Q&A function is an evaluation form. We really appreciate your feedback, so let us know how we went. So, firstly, today we have Professor Andrew Spencer talking on why is myeloma so unique. There will then be a short 5-minute break. Professor Ben Tay will then speak about preventing infection and strengthening the immune system, and Dr. Veronica Johnson will discuss the emotional stress of myeloma. Our last presentation is a consumer perspective on the multiple faces of myeloma. So I would like to warmly welcome Professor Andrew Spencer. Professor Spencer is head of the Malignant Hematology and Stem Cell Transplantation Service at the Alfred Hospital, Professor of Hematology at Monash University, and group leader of the Myeloma Research Group within the Australian Centre for Blood Diseases in Melbourne. He has been an invited speaker to numerous international meetings on genomics, therapeutics, and disease monitoring in multiple myeloma. He serves on the scientific advisory boards of the International Myeloma Foundation and the International Myeloma Working Group, and chairs the Myeloma and Related Diseases Registry and the Australasian Myeloma Research Consortium. So great to have you with us today, Andrew, and over to you.
So thank you very much, Deborah, for that kind introduction. So my topic today is why is my myeloma so unique? So this is a very, very complex question. And so there's a very complex way to answer this, or indeed there's a more straightforward or understandable way to answer this. So the more complex way to do this will be to start speaking about genetics at great length, but I don't think that's really what we need to be talking about today. And so I've taken the position, I guess, to try and explain this by saying what are the various factors which impact how my myeloma behaves, because I think as a patient you'd be interested, why is mine behaving differently to other people and so forth. And from that perspective, I think that the way to look at this most sensibly is in fact to think about the disease itself, to think about you, the patient, and then to think about your treatment, because all of these things influence how your myeloma behaves. So first, if we think about the disease itself, myeloma is one of a quite complicated group of disorders, which are called plasma cell dyscrasias. And all of these disorders are characterized by abnormal populations of plasma cells. Now, plasma cells normally reside predominantly in the bone marrow, but also in the spleen and some of the lymph glands and the gut. And they're the cells that make antibodies for the body. So they're not actually made in the bone marrow, they're made elsewhere, then go and live in the bone marrow. And that's why myeloma is largely a disease of the bone marrow. And as you can see from this list, there's a whole pile of other disorders which affect plasma cells. And in fact, sometimes it can be very difficult differentiating some of these disorders from multiple myeloma. And that's one of the challenges we have with diagnosing the disease accurately and therefore instituting treatment in a prudent fashion. So here's just a cartoon of these different disorders. And you can see this is quite old data now from the Mayo Clinic. But the commonest plasma cell disorder is monoclonal gammopathy of undetermined significance. And everybody that has myeloma has had this disease before they got myeloma. So we call it MGUS for short. So you can't have myeloma unless you've got MGUS beforehand. And the differentiation between different patients starts at this level, because we know that only 1% of patients with MGUS each year will develop myeloma. So there's clearly dramatic differences, even at the MGUS level, before myeloma develops between different individuals. So the cardinal features of myeloma I've listed here. We've got anemia, kidney problems, bone problems, high calcium, the presence of that paraprotein in your bloodstream, and we'll talk a little bit more about that. And of course, the risk of infection, which Ben will address later, that's a cardinal feature of myeloma, because as you can imagine, if your normal antibody making blood cells are disrupted by this disease, you're going to be prone to infection. And that's one of the problems which patients frequently face. So before I go into that, just a picture here, this is what the bone marrow looks like with multiple myeloma. And these cells are plasma cells. And you can say to yourself, well, you know, they'll look pretty much the same to me. And in fact, that's the problem. In myeloma, they are pretty much the same in that they're clonal cells. Whereas in an individual without myeloma, the cells are what we call polyclonal, because all the plasma cells make different antibodies. So in patients with myeloma, we've got this massive expansion of clonal plasma cells, which don't really make useful antibodies. And they tend to pack out the bone marrow, leading to some of those features, which I'll describe to you in a moment. So one of the cardinal features of myeloma, and you'll all be aware of this, is the fact that it makes, in most cases, a protein detectable in blood called a paraprotein. So we look at proteins in the blood with a really old-fashioned test called a serum protein electrophoresis. And this is a serum protein electrophoresis from a person without myeloma. And you can see that there's like a smudgy thing down the bottom and then like a squiggly line at the top. And what this is telling us is that the most abundant protein in the bloodstream is this ALB. This is albumin. So this is a good protein we all have in our blood in large quantities. And then on the right side, with that little gamma symbol, there's like that lump. This represents all the normal antibodies in the bloodstream. So these are gamma globulins. And if you look down at the smudgy thing at the bottom, you can see on the right side of that, there's like a broad, dark smudge. And this represents all the different antibodies present in the bloodstream. In a person with myeloma, you can see there's a striking difference in that smudgy bit on the right has now been replaced by this band or M-band or paraprotein. And you can see that the graphic above shows this big spike. And that is protein being made by the abnormal plasma cells. So you can't have a paraprotein like this unless you've got the abnormal plasma cells making it. It's a bit like smoke to a fire. And so this is the biomarker or the thing in the bloodstream that in most cases your doctor monitors to track how your myeloma is behaving. But this biomarker or paraprotein in patients is actually different in different patients because there are different forms of paraproteins. If you look at the cartoon on the left, this is just a cartoon showing what a paraprotein looks like. It's made up of 4 bits of protein, 2 big bits, 2 small bits. The big bits are called heavy chains, the small bits are called light chains. And the big bit, the heavy chain, can be in IgG, A, D, or M, and they're all different. And the light chain bits, the small bits, can be kappa or lambda. So there's all these different versions of that people can have. So there's a point of difference right from the start that your myeloma might be making different paraproteins. And these behave differently and can have different implications. And when it comes to the light chains, some myelomas only make the light chains. About 20% of myelomas only make light chains, and that's light chain myeloma. So again, that's different to patients who've got a paraprotein. And the light chains can be kappa or lambda, and that's important as well because lambda light chains have got a greater tendency to affect the kidneys. And so again, that can change the clinical picture and make a point of difference between patients with kappa or lambda multiple myeloma. So we can actually identify what sort of paraprotein people have got, again, by one of these smudgy sort of lab tests that we do. And here you can see there's like a dark smudge on the G band towards the right. So this is telling me it's an IgG paraprotein. And then directly below that, where there's a K and an L, you can see there's a band on the kappa or K bit. So that means it's a kappa. So this is an IgG kappa myeloma. So this is how we identify what sort of paraprotein or light chains your disease is making. So the trouble is that even though we know that the plasma cells in myeloma are clonal, and that makes us think, well, they're all identical, it's actually a bit more complicated than that. In that within that clonal population of plasma cells in someone with myeloma, there's all distinct little families or subclones. And these subclones can actually have different genetic abnormalities from other subclones. And this is within the same patient. So if you then think about the fact that you might have 100 patients, all with different subclones of plasma cells in them, you can start to get a feel for why it is such a variable or heterogeneous disease. Can be dramatically different between individuals because of this complexity at a genetic level. And like I said, only 1% of patients per year get myeloma from MGUS. So again, highlighting the differences in patients with MGUS, who even at that stage can have these different families of abnormal plasma cells. We've done a lot of work, as have other investigators, looking at the genetics of myeloma, doing sequencing, DNA sequencing of the abnormalities in plasma cells. And this is just one example of one of the things we've looked at a few years ago, where we had a patient where we did two biopsies. We did a biopsy of the bone marrow, and we did a biopsy of a rib lesion, and we did the DNA sequencing of both of these lesions, and we showed that they were quite different. So even in the same patient, the disease at the same time can be different at different locations within the patient's body. So explaining to you this sort of genetic complexity. And this can sometimes underlie what we see when we treat some people with myeloma, in that in parts of the body, the myeloma will get better, but in other parts, it might not. And that's because of this underlying what we call spatial genomic heterogeneity. It can be different in different spots in the same person. So if we go back to these clinical features, I've listed them here, and we'll speak a little bit more about that now. So when you're suspected of having myeloma, you'll have a whole range of tests done, which you'll be familiar with. These are things like your blood count, kidney function. You'll have your protein electrophoresis done. You'll have certain things in the bloodstream measured, which tell us a bit about what stage of myeloma you've got. You're going to likely have 24 urine collections to look to see whether any of the myeloma proteins in the urine, and has that got implications for your kidneys. When a person is diagnosed with myeloma after those tests have been done, there are certain symptoms that a patient may have. And it's important to understand the difference between having symptoms and what a doctor would call signs. So symptoms are what the patient complains of. I've got bone pain, I'm tired, I've lost weight. Whereas signs are things that might be given on x-rays or scans or blood tests. So they're objective things which are measured. So when we look at the symptoms that patients might have, you can see here the commonest symptom is bone pain. So 58% of patients in this publication describe bone pain, but that means that 42% didn't have bone pain. Similarly, a quarter of the patients here had weight loss, but 3/4 didn't have weight loss. So right from the beginning, patients can have different symptoms when they present with their multiple myeloma. And then this is borne out when we look at these signs or clinical features. So as expected, most people will have a paraprotein or M protein. When we do x-rays and scans, we see that about 2/3 of patients have got evidence of bone lesions, which we'll describe in a minute, but that means 1/3 of patients don't. And some patients actually never get bone lesions. So again, this is an important reflection of the fact that the genetics of the disease in patients can be quite different. A lot of people get anemia because those plasma cells are invading the bone marrow, but a quarter don't, because some people actually don't necessarily have a lot of plasma cells in the bone marrow, but still have multiple myeloma. So again, these features can be very different between patients. So these are some x-rays of a patient with multiple myeloma. You can see these little holes, these dark areas in the bone. These are what we call lytic lesions or punched out lesions. And these are due to areas where there's lots of these abnormal plasma cells within the bone marrow. And in fact, when the first archaeologists started digging people up in Pompeii from ancient Rome, they found individuals with lytic lesions in their bones there, telling us that myeloma has been around for a very long time. It's not just a disease of modern people, it's been in humans for thousands of years. So these lytic lesions are a cardinal feature of the disease, and some patients have them and some patients don't. One of the things that can happen when we've got these sorts of lytic lesions developing is that they can occur in parts of the body that are critical. So for example, if we have a lytic lesion develop in the vertebra, that can cause a lot of trouble in relation to the spinal cord. So some patients may be unfortunate enough to have vertebral lytic lesions, whereas other patients won't. So again, there's significant differences between individuals. So what are the different bone lesions or SREs, skeletal related events that patients can get? So we can see fractures of the bones, we can see damage to the spinal cord, there may be a necessity for radiation treatment to lesions, there may in fact be necessity for surgery. So often we will call our orthopedic colleagues and ask them to look at maybe one of the leg bones and say, does this need something doing to stop it breaking? So people sometimes will have prophylactic operations where metal rods are put in the bones to strengthen them, to stop them breaking. So all these different features are features of the bone disease in myeloma. So again, if you mix and match these different things, you can see how there can be a dramatic difference between patients, depending how their particular disease is behaving. Now, speaking about the patients themselves, okay, we know that myeloma is a disease largely of older people with an average age of diagnosis around 70. But here, this is some data from the UK. It's old now, but nevertheless, it holds true, is that you can see there are young patients in their 30s and 40s with multiple myeloma, and then patients in their 50s, 60s, 70s, 80s, and so forth. So again, you can imagine you've got the variability in the disease itself, but then you've got the variability between the patients that actually have it. And the age of the patient has a significant impact on how the disease will play out. So this is some data from the registry that I've been involved with for a number of years. And this is looking at survival in myeloma in Australia. This is in real world patients. This is not in patients on clinical trials. So you've got to keep in mind that this data relates to therapies that we've had before we looked at this. It does not tell us about what these newer therapies will do to survival. So this sort of picture is constantly changing. The thing to keep in mind here is that the blue line is patients who are under the age of 70 with myeloma, whereas the red dotted line are patients over the age of 70. And you can see there's a significant difference in outlook for patients depending on age. And this is not driven largely by the biology of the myeloma being different in young and old, although there are some differences. is driven largely by the fact that older patients have got more significant health issues. So they might have heart disease, lung disease, they may have pre-existing kidney disease. And all these things will impact on how well the patient tolerates the diagnosis of myeloma and what it's doing, but also how well the patient will tolerate treatment. So it's a lot easier to treat a 45-year-old aggressively for myeloma than it is a 75-year-old. And so these are differences which impact on how the disease behaves and the outcome of the disease. So we've studied very closely what factors, patient-related factors, impact on outcome. And what I wanted to show you is just these bits in red. And if you look at this table here, under the heading odds ratio, there are various numbers. So this number, if it's above 1, means that the characteristic to the left, so age or performance status, is bad. So if you've got an age over 75, the odds ratio is 3.1. So that means that you're far more likely to have trouble in controlling and surviving your disease than someone who's under 75. Similarly, if you go down the table, look at cardiac disease, pulmonary disease. These are problems which are increasingly common as we get older. You can see the odds ratios there around about 2 or 2 and a bit. So these factors impact on outcome for patients, largely because it impacts on how you can treat the patient. So these different patient characteristics also add to why the disease in an individual can be quite unique. It's not just the disease, it's the patient themselves, and that dictates what you can do or cannot do in terms of treating the disease. Now we know the disease it's interesting in that it will respond to treatment, but then after a variable period of time, it will relapse. It invariably relapses. And I've seen patients where this relapse may be within 3 or 4 months, or it may be more than 10 years down the track. And this is in patients who receive the same therapy. Now, in that case, that's driven by that underlying disease biology. So out of all the myelomas that we see, there are some which are good versions of a bad disease, and then there are versions which are bad versions of a bad disease. And that's the genetics underlying the disease. And that really determines the duration of response to treatment, or everything else being equal, people getting the same treatment. So these days in Australia, the major decision about managing myeloma boils down to whether someone's transplant eligible or not transplant eligible. So in patients who are transplant eligible, they'll have some form of what we call induction therapy to control the disease. Then they'll have a transplant. Then they might have a bit more therapy, and then they'll have some maintenance therapy. In patients who are not fit enough for a transplant, they just get treated with similar therapy to the induction treatment that the first group of people get, but then it's continued on in an ongoing fashion, usually then followed up with some form of lenalidomide maintenance. And there's various drugs which are available for newly diagnosed patients, albeit in a limited fashion. And these are generally used in a similar way, both in younger and older patients. The difference is the transplant thing. So what about response to treatment as the final arbiter of uniqueness between patients? Okay, so this is some data from my department at the Alfred Hospital. And some of you would have heard about the fact that now we're moving into the realm in myeloma of needing really sensitive tests to measure what disease patients have, because their paraprotein's gone, their bone marrow looks normal. So we now have super sensitive tests which measure what we call minimal residual disease. And we've been doing this for a number of years here with a test called Euroflow, which can pick up 1 myeloma cell in 100,000 normal cells. So if this test is negative, it means there's less than 1 myeloma cell in 100,000 normal cells. So very low tumor burden, and that's minimal residual disease negative. And the graph here shows you the impact of that. And the patients on the green line are patients who have achieved minimal residual disease negativity and gone on to maintenance therapy. And so they're all staying in remission as we follow them up. The unfortunate patients on the red line have not achieved minimal residual disease negativity and didn't, for whatever reason, go into maintenance therapy. So you can see that the response to therapy and the interaction with ongoing therapy is a huge determinant of how the disease behaves. And if all things are done in an optimal fashion, we can't really do more than that. So what I'm saying is that if everything is done properly, right therapy, right doses, right sequence of therapies, that's all you can really be asking for in terms of how to get things in control. And then there are some factors which are intangible, which we can't change, and that's the underlying biology of the disease. So from your perspective, what you have to ensure is that you're getting the right therapy in the hands of the right person looking after you to make absolutely certain that you're getting the most bang for your buck, if I can call it that way, for the therapy that you're getting. So there are disease characteristics, there are patient characteristics, and then there are treatment variation in response to treatment, all of which impact on how your myeloma behaves. And we only have control over some of those elements. And that's why you can have a room full of people with myeloma and it's all behaving differently, doing different things, because it's a very complex interaction of all these different factors. And I think that was my last slide. So I'll finish there, and I'm happy to take any questions in relation to that, or indeed anything else that pops into your mind. Thank you for listening.
Thank you, Andrew. Look, that was terrific. You've explained extremely well the uniqueness of myeloma, you know, it being so complex and how changeable it is between people. And you even talk about, you know, the DNA sequencing and it presenting differently in the same person in different locations in the body. This all must make it incredibly difficult to treat person to person. Can you expand on that?
Yeah, look, one of the real issues I think a lot of clinicians have with myeloma is that, for reasons which I won't go into, it's the wrong forum, but for reasons, we treat everybody the same way basically when they first present, apart from transplant versus no transplant. And this really belies the fact that we know that there's massive variation between patients in terms of their prognosis. And that's largely because there's a limited armamentarium of therapies available where we live for newly diagnosed myeloma. So it's not like we can go to the cupboard and we've got a dozen different medicines and we select which ones are best for the patient, you know, which will be a more personalized approach. I think that time is coming, but at the moment, clinicians are very, very cognizant of the fact that we're treating Fred the same way as Bill, and we probably know that we shouldn't be treating Fred the same way as Bill. But at the moment, therapeutically, that's the situation we're in. But I think it's going to be changing. So what we do initially with patients is basically treat them in an optimal fashion with what therapies are available. The one difference there is perhaps if we've got a very elderly patient, where we may adopt an approach where we say, well, we'd like to treat this and we'd like to keep the patient on treatment, but we want to really make sure it's not too toxic. Because a critical factor is actually keeping people on treatment. If you stop it too early or dose reduce too early, that impacts very badly on outcome. So there is some variation depending on frailty. We've got a clinical trial looking at that we're running at the moment, trying to, you know, optimize treatment for frail patients. So everyone gets treated the same, perhaps except for that frail group of patients who can't tolerate more standard treatment.
Thank you. And we are all heartened. There are new therapies, you know, coming out all the time. Peter has a question. So with smoldering myeloma, he says it's really hard to sit still and wait for the inevitable. So if we have smoldering myeloma or MGUS, Is there anything we can do to prevent it moving into myeloma?
Okay, so there are a couple of points to be mindful of. If you've got a group of people with MGUS, for all of those patients to get myeloma, they'd all have to live for 100 years. So first thing to keep in mind is only a small proportion of patients with MGUS ever develop myeloma. So you've got a far greater risk of, unfortunately, getting some other horrible disease as you get older. Okay, with smoldering myeloma, there's a lot of debate about, well, is there a proportion of people with smoldering myeloma that should get treated that have got high risk smoldering myeloma? Okay, you know, they're sitting on a time bomb. These people are going to get myeloma. But the models to identify patients with high risk smoldering myeloma are actually very poor, in that people with and without high risk smoldering myeloma can get myeloma, but they may not. And in fact, only about 50 or so % of patients with smoldering myeloma will get myeloma. I know that sounds like a lot, but it means a lot of those people, like the MGUS patients, won't get it. So it's not inevitable. And I think you must be understanding of that. And I think it's also important to realize that even if we had a range of drugs available to treat smoldering myeloma, the challenge is that, as I've said, we can't identify who should and should not be treated accurately. And that raises the possibility that a large number of patients with smoldering myeloma will be getting treated with very expensive, potentially toxic drugs when they're never going to need that. So the real challenge with smoldering myeloma is understanding who's going to get active or symptomatic myeloma. And unfortunately, we're not in a position where we can do that yet. But again, there's a lot of advances being made in that space. But I think you must be mindful, this is not an inevitability, whether you've got MGUS or smoldering myeloma.
Thank you. Thanks for that. Pauline asks, do PET scans identify different areas affected by myeloma? Would it help decide what treatment is most suitable?
Okay. So, if you've got newly diagnosed myeloma these days, you may have a CT scan of your body, what we call a whole body low dose CT scan, which is a super sensitive way of looking at the bones. It's great. But that just tells you about the anatomy. Is there a bone lesion or isn't there? Doesn't really tell you anything else. A PET scan is a functional test. It actually tells you where there's areas of active myeloma disease, which may or may not correspond to those lesions you see on a CT scan. So they give you quite different sorts of information. One sort of structural and one sort of functional. And PET scans will highlight myeloma present in the bone marrow. It can also detect areas of myeloma that is growing outside the bone marrow, what we call extramedullary disease. In most cases, a PET scan at diagnosis is not going to change how you're managed. It's going to be just a piece of information at the time of diagnosis, which can be looked at later on. So you have a repeat PET scan. Has the PET scan now normalized? Or is there a problematic area of disease that's not responding, for example? Or at the time of diagnosis, in some instances, is there an area of disease visible on the PET scan which might need some radiotherapy or localized treatment? But largely speaking, a PET scan will not change how you're managed if you're newly diagnosed with myeloma. It just presents a very sensitive and sophisticated modality to gauge the extent of the disease and to look at the response of the disease. So it's just a new way, a more sensitive way of monitoring the disease combined with your blood tests, basically. It's a great test, but it won't necessarily change how you're managed.
No, understandable. There is another question from Donna. She asks, what is your opinion on stopping lenalidomide maintenance after 3 years due to the risk of other malignancies?
Yeah, this is highly contentious. I was on what's called the Safety Data Monitoring Committee with a French study that studied maintenance lenalidomide. And that study was happening at the same time as an American study. And there were subtle differences in the treatment they used in France compared to the Americans before maintenance started. And the French pulled the plug on their maintenance, saying it should only be given for 2 years because of the risk of second primary malignancies. Okay, and that's quite valid. The Americans, however, say no, you should continue the lenalidomide until progression. So two very different opinions from clinical trials. So the issue here is complicated in that nobody should stay on maintenance lenalidomide, in my opinion, if it's having an adverse effect on their quality of life. If you're miserable taking lenalidomide, you shouldn't be on it. It's better off for you to be feeling well and doing what you want to do rather than taking a drug which should prolong your remission, but may not in your case because of the underlying genetic variability I've mentioned. The other thing is, I was involved in some work quite a long time ago looking at this issue of second primary malignancies. Okay, now this sounds somewhat silly, but if you succumb to your myeloma, the issue of whether you're going to develop a second primary malignancy is completely irrelevant. Because the big fish that you have to fry if you're diagnosed with myeloma is the myeloma. It's by far and away the biggest risk to you and your survival. And in fact, using lenalidomide, irrespective of the risk of second primary malignancies, results in a better outcome because the myeloma is the biggest danger. It's not the risk of another malignancy. So it's a complicated issue, but, you know, should you worry about myeloma now or something down the track? Well, I think you should worry about myeloma now, to be frank. The duration of therapy is highly contentious, but I think if you're tolerating lenalidomide maintenance therapy, you should stay on it. If you're not tolerating it, you should stop. As simple as that.
And I think you bring up a very good point, you know, people staying on things and perhaps it is making them very unhappy and they're not well on it, and raising that with their hematologist and not being able to tolerate a drug. It's quality of life, isn't it? And
absolutely.
Absolutely. One more question, I think, before we go to our break. Somebody asked, does having renal symptoms make my prognosis worse?
By that, I think you probably, if your kidneys aren't working as well, does that make my prognosis worse? I guess the short answer is yes. But largely these days, because if your kidneys aren't working properly, it can impact on some of the drugs that are used or what dose of drugs are used. Because the kidney not working normally has no bearing on how the myeloma behaves. It's actually one of those patient factors I was referring to. So a patient whose kidneys aren't great compared to a patient who's got normal kidney function, well, that's going to impact on treatment. So sadly, yes. In fact, we've got some patients here that have ended up having kidney transplants to restore normal kidney function. And the driving force there has been that we've convinced our kidney transplant doctors that if these patients have got restoration of their kidney function, they'll have far more options therapeutically down the track, including going on to clinical trials. So, yeah, unfortunately, yes, it will impact on how the disease can be managed, but it doesn't affect the disease per se.
Well, Andrew, thank you so very, very much today, you know, taking time out of your busy schedule to inform us. And it's been a great talk. Thank you so very much. We will now go to a 5-minute break before Narelle introduces the next sessions. Thank you.
Bye-bye.
Hi, thank you.
Welcome back from the break. My name is Narelle Smith and I'm the myeloma support nurse for Western Australia, and I'm coming to you today from Whadjuk country. I'm so happy to be here today as part of National Myeloma Month and our second online seminar, and I hope you are all refreshed now after the break and ready for our next speaker. Associate Professor Bente is an infectious diseases physician and clinical researcher at Peter MacCallum Cancer Centre and the National Centre for Infections in Cancer. His research interests in the area of infections in cancer patients encompass translational immune profiling for infection risk prediction, clinical studies of infection risks with new cancer therapies, and clinical trials of vaccination in haematology patients. And today, we are very lucky to have Ben speaking to us about infection prevention and strengthening immunity. So welcome, Ben. Thanks so much.
Thanks, Narelle, for the kind introduction, and certainly thanks to Myeloma Australia for the kind invitation to speak today. Before I start, I just wanted to declare these are my disclosures. And I think, I do apologize that some of the slides are more technical and very clinically focused, but I think, it's good to sort of put it into, I'll try my best to put it into context for everyone. So before we can talk about, preventing infections in, patients who have myeloma, it's often important to think about what are some of the patterns of infections that we do see in looking after myeloma patients. I think the first thing, as you can see from this slide, is to think about the different phases of myeloma treatment from when people first start on treatment. For those who are more transplant eligible, And then unfortunately, later on, when there's disease progression, that the patterns of infection, as you can see, summarized in this slide, can be very different. So at the start, it tends to be perhaps more bacterial infections, whereas during stem cell transplant, there are different phases of recovery after stem cell transplant. In the early days, again, more likely to be bacterial type infections, but later on, viruses become more important, especially viruses that we have encountered before growing up, which can come back again as what we call viral reactivation, or picking up new viruses, as we all know from the recent pandemic, things like viral respiratory tract infections, like unfortunately COVID and influenza and other respiratory viruses, which perhaps are less commonly known, but unfortunately certainly affect all of us. Aside from the treatment phases, sometimes there are certain types of infections that are connected to particular types of therapy. For example, proteasome inhibitors such as bortezomib, there's an association with what we call herpes zoster, which is the chickenpox virus reactivating. And so we then have to try to target that more to try to prevent that from happening during treatment. There are also some associations, such as with what we call high-dose steroids and a particular type of infection called pneumocystis, which is an unusual type of fungal infection that can affect the lungs. So that's why often when a number of myeloma patients, when you're on corticosteroids or dexamethasone, that's when you notice that you're on a preventer as well during that time. So this is more just to summarize the different patterns of infection that we do see across the different phases of myeloma treatment, and also associated with certain types of treatment. These summary slides are just more to give everyone a bit of a flavor that, you know, depending on the type of treatment, the rates of infection can certainly change. In general, when someone's starting out, the rates of infection generally range between 10 to 20%, whereas later on, you know, when we use things like monoclonal antibody therapy, which is the MOABs, as you see in that slide there, and things like daratumumab, alatuzumab, and when it's more used for when the disease is more active, that's when we see perhaps a slightly higher rate of infection between sort of 20 to 30%. But these are things that we anticipate, you know, can happen, and therefore then, as you can see from subsequent slides, we'll talk about how we can try to reduce the risk for these infections. So I'm just covering here in this other part of the slide, the newer generation therapies that some people might be on them as part of clinical trials. For example, bispecific antibody therapies and CAR T-cell are very new in the myeloma treatment space. And certainly these are early reports of the type of infection patterns and rates that we see with them. So in terms of what the risks are for infection, I always like to think about it as several factors. One, of course, at a patient level, it depends on how someone's performing and how active someone can be. And certainly the more active someone is, the lower the risk for infection. Then there are some risks for infection connected to the myeloma itself. So for example, unfortunately, having a higher burden of myeloma can mean a higher risk for infection, and certainly things, for example, that the myeloma itself can impact, such as low red blood cell count, low white blood cell count, can certainly impact then on risk for infection as well. Then, as I touched on before, there are some treatment-related factors. So it's the types of treatment, the use of steroids, and certainly how much treatment someone has had before can certainly impact on their risk for infection. So how do we try to prevent? That's all the bad side of things, but certainly let's think about how we can try to prevent these infections from happening in the first place. So I like to think about it in sort of several steps. I think one of the key steps is to, of course, control the myeloma, because when we know that there's less myeloma around, or if there's very little of it, then certainly the immune system can recover, and therefore then the risk for infection is lower. Now, that's something as an infectious diseases doctor I can't do much about, but of course that's where your clinical team, your myeloma clinical team certainly play a huge role in the first point. But what we do advise about is what we call prophylaxis. So what can we take on a day-to-day basis or maybe a couple of times a week to try to reduce the risk for those infections that I've highlighted before. So for example, we can't just use, this could be antibacterials or antibiotics or antivirals, and some types, slightly different ones called antifungals, which we don't use that often, but we can't just use it all the time in everyone. So therefore, it must be targeted to when someone's most at risk, for example, after a stem cell transplant, or targeted to certain types of treatment, as I'll go through later on. So what about things like, if someone's immunoglobulin, which is basically antibody levels in our bodies, if they are low, then whether, replacing that could help, reduce the risk of infection as well. And of course, vaccination is very important because that helps to strengthen our immune response and our immune system to help ward off some of these infections that we'll cover. So again, these are slightly, further details of it, but certainly what we call antibacterials are quite, commonly used, and of course for treatment of infection. But how in these couple of slides, I'm just trying to highlight how, there's been some studies to look to see if we can take it regularly to prevent infection. So in this case, in the much older studies, there perhaps shows that when we use these types of antibiotics, so trimethoprim sulfamethoxazole is Resprin or Resprin Forte that people might come across or be well familiar with. And fluoroquinolones is a type of antibiotic called ciprofloxacin or levofloxacin. And in those early studies, taking it regularly to try to prevent infection, unfortunately, didn't really make much of a difference. But in a later study, the use of a type of antibiotic called levofloxacin showed that perhaps there was lower rates of fever and certain types of infection, but unfortunately it made no difference to the overall outcome of the disease, when we follow patients up for much longer. But what was worrying to us is the use of, as I'm sure we can appreciate, when you use antibiotics for a very long time, then there's a risk of what we call resistance developing. So the bacteria in our bodies and our guts becoming then more resistant to the particular antibiotic that has been used more regularly. So there's always a trade-off that while, sometimes having antibiotics regularly can be helpful, other times there are always, unfortunately, a downside to it as well, in particular, what we call the emergence of more resistant bacteria. So again, not to go labor the same point, that was for when people first start their myeloma treatment course. And this slide is more to cover the point about during stem cell transplant. If we use antibiotics regularly to prevent infection, does it actually work? So again, much similar to what I've discussed before, the rates of fever perhaps could be lower, no difference in what we call mortality or outcomes from myeloma. But unfortunately, because we're using these antibiotics more regularly, then the emergence of resistance to those antibiotics. So at the moment, we are not recommending that people take these types of antibiotics routinely. Of course, these are considerations for your doctors to discuss with you what's appropriate. This is just general patterns. It doesn't mean that it's specific to everyone's situation. So what we're saying is that it's not routinely recommended for everyone to always have antibacterials for during the start of treatment or for stem cell transplant. It's very different to treatment of an infection. So once you have fever or once you have a proven infection, this is a very different scenario, of course. So we say that, of course, everyone's situation is different, and it can be considered if, unfortunately, someone tends to get lots and lots of infection, then perhaps this is a way to try to reduce the burden of that. So what about antiviruses? So there are, for example, certain key viruses like what we call herpes zoster. So there are various types of herpes viruses, but the two most common ones are herpes simplex, which is the cold sore virus, and herpes zoster, which is the chickenpox virus. And so once we get exposed to these viruses as we grow up and get older, unfortunately, they never disappear from us completely. They remain dormant in our cells. And then, when unfortunately later on in life, when we need certain types of treatment, for example, like myeloma treatment, then there's a risk of it coming back again. So that's what we call reactivation. So for the two main viruses that I've mentioned, which is the herpes simplex, the coastal virus, and the chickenpox virus, to try to prevent it from coming back, we do have antiviruses that we can use to try to reduce that risk. And like I said, again, not for every situation and for everybody, but for certain key periods. For example, after stem cell transplant, when people are on it for up to 12 months after the transplant, to try to reduce the risk of this happening, because we do know from very good studies that that is what happens. So of course, we anticipate that risk of happening, and therefore then we put people on these antiviruses for up to 12 months to reduce that risk. Hepatitis B is a type of virus that people can get exposed to depending on where in the world they were born and where they've grown up in. And so if, for example, you've been exposed to hepatitis B before or have had hepatitis B before, we again recommend a preventative course of antivirals, but again, not for everyone. There are certain viruses, for example, again, the cold sore virus and the chickenpox virus, associated with certain types of therapy, especially the main ones, which I've touched on before, are things like bortezomib and carfilzomib, tend to be associated with the chickenpox virus coming back, so what called zoster reactivation. And so when those treatments are being used, that's probably when you see that your clinical team would recommend that you take valacyclovir or acyclovir to try to reduce that risk for happening. So again, a very more targeted approach to things. What about antifungals? Now, we don't tend to think of antifungals that commonly, because by far the most common thing we think about, of course, are bacteria and viruses. But unfortunately, in certain types of situation, fungus can become important to try to prevent. So as highlighted in this slide, the first situation would be after stem cell transplant, because our immune systems are low, and a type of immune cell called neutrophils, which help to fight fungal infections, can be very low, and it takes time for that to recover. And so during that period when it's waiting to recover, I'll go back. When it's waiting to recover, that's when you need to take an antifungal called fluconazole to try to reduce that from happening. Then later on, we touched on before that when you're on steroids in particular, I'll move the slide forward. When you're on steroids, there's this risk of this more unusual and uncommon type of infection called pneumocystis. And therefore then Resprin Fort is the type of antifungal. It's also an antibacterial, but it's used there for that purpose to try to prevent this type of infection called pneumocystis. So that's when you might see that when you're on steroids, you're recommended to then be on Resprin Fort as well. And of course, the suggested time there is when you finish your steroid or steroid courses, that's when you could potentially then come off Resprin as well. So I think, that's what, by far the most common sort of approaches that we use for the vast majority of myeloma treatments. But what's definitely very exciting, which I'm sure your myeloma clinical team will discuss more with you all, is that there are great new generation treatments for myeloma. And just highlighting here that unfortunately from the infection side of things, we're always a little bit behind in terms of our data about infections with regards to the newer generation types of treatment. So as a result, as you can see here, that the recommendations are not as strong when it comes to the new generation treatments like the bispecifics and like CAR T-cell, where we use some of the data that we know from stem cell transplant and other conditions, or CAR T-cell for other types of cancer, but it's not, the data here is not as strong as I previously discussed with the other types of treatment. So immunoglobulin, I've touched on before. Immunoglobulin is antibodies that are in our bodies that help to fight against and prevent certain types of infection. But we do know that unfortunately, when patients have myeloma, as a combination of the myeloma itself, but sometimes the treatment for myeloma, those antibody levels can be low. It doesn't happen in everyone, but certainly it is possible in some people. So the key thing is that when it's very low, these are some of the levels that we suggest for clinicians to think about, is that when these antibody levels are very low, that's when your clinicians will start doing the workup and to think about whether you need the replacement. So basically replacing it either through once or twice a month, an infusion called IVIG, or giving it subcutaneously, just under the skin, to try to top up these antibody levels. And we do know from good studies that certainly, again, not for everyone, that replacing it can reduce the risk for some serious infections, especially if people have had those serious infections before. So vaccinations, I think, is one of my passion areas, and I certainly think it's very important to think about. And we do, obviously, there's been a great focus on it over the last couple of years with COVID. But our recommendations for vaccines have way preceded COVID for a long time. So these are some of the recommendations that we do give clinicians to have a think about. One of the main ones is against the bacteria, the main bacteria that can cause bad pneumonia and bad meningitis, called pneumococcus. And ideally, at disease diagnosis, that's when people should be vaccinated. And what is recommended there with the little names are two different types of pneumococcal vaccine. One is called Prevnar 13, that covers 13 strains of this bacteria, and followed by pneumococcal 23 or Pneumovax 23, which covers slightly broader strains. And it's given in combination with each other because they both help each other expand the protection against this particular bacteria. So that's one of the key infections that's very important to be vaccinated against. The second one, of course, before COVID was influenza, which was can trouble myeloma patients quite a fair bit, especially during winter time. There is a particular formulation called the adjuvant vaccine, or sometimes people call it the old people's vaccine, which I'm not a fan of the name, but of the term, but certainly that's the one that people hear about, where it's given for patients who are 65 and above. Usually for most people, only one dose is recommended, and that's what's recommended under the National Immunization Program. But there's some early data that suggests that perhaps 2 doses could be better. But like I said, this is not reflected, and it's certainly not a formal recommendation in our immunization schedule. But that's an area that could be sort of developed further in the next couple of years. And when it comes to COVID, of course, it's hard to give any talk about infections in anyone nowadays without having to touch on COVID. But certainly, of course, hopefully most people already have had what we call their 3 primary doses. And now for most of our patients, we're going on to recommendations around booster doses as well. Now, while those are the main infections, we often should not forget other types of infections like the meningitis, the main bacteria that can cause meningitis called meningococcus, and Haemophilus, again, a less common bacteria, but certainly a common cause, can lead to meningitis as well. So often those things are also important to be vaccinated against. Now, what I've just highlighted there in the last point is that while we always think that treatment can, negatively impact our responses to vaccination, and that's certainly true with certain types of treatment like daratumumab, but other types of treatment like, for example, lenalidomide or Revlimid can actually perhaps even improve our vaccine responses. So it's not all negative from the treatment point of view. So this is just a summary table looking at the recommendations for patients, especially following stem cell transplant, as those who have gone through a stem cell transplant before know that the intense chemotherapy that we give to prepare people for stem cell transplant, unfortunately, takes away some of the pre-existing immunity that you might have either from prior vaccination or prior infection. And so we do recommend a program of revaccination after stem cell transplant. And I think, you know, an important one to highlight, which is a newer vaccine, which some of you might have heard about, is against the chickenpox virus from coming back, or shingles. And of course, there are two types of shingles vaccine. One is a very strong live vaccine, which we do not recommend, called Zostavax. But the safer option is certainly this what we call inactivated or killed vaccine called Shingrix, which unfortunately is not funded yet under PBS. But it is, because it's an inactivated vaccine and does not contain any live virus, is a much safer and effective option. So certainly it is recommended after stem cell transplant, but unfortunately not that widely available as yet, because of the majority of the reason is because of the cost of this vaccine. But we can certainly, you know, talk about it further on during question time. But this is just a summary of the schedule that we do certainly recommend. And here at Peter Mac, we offer this program after stem cell transplant to all our patients. And, you know, this is something that has happened more recently as a result of the COVID pandemic, that because we do know that some patients don't respond as well to vaccinations. Certainly, you know, so for those who don't tend to, we have this, or we used to have this, what we call long-acting antibody. So it's different from a vaccine. Vaccines train our own immune system to make a response to the particular bacteria, to that particular virus, whereas these are a bit like those immunoglobulins, but it's just more long-acting and given as a medication, also as an injection. So that's why sometimes there's a confusion for people whether it's truly a vaccine or not, but it isn't. But it's a treatment that lasts for 6 months to try to top up those antibodies in people who may not respond as well to the vaccine, to try to prevent COVID from happening. And certainly we do know that it has been effective when it was first used last year, well, from the middle of last year to the end of last year, where when it's used, it was associated with lower hospital admission and death. And certainly the breakthrough rate, while still occur, I think no treatment or no prevention is always perfect. There have been breakthrough infections while on this particular therapy, but very fortunately, most episodes of infection have been mild. But unfortunately, as you might have noticed with some of the recommendations from your doctors and treating team, that is unfortunately the current strains of COVID circulating, it's not effective against. So therefore, it's no longer recommended beyond the start of this year. So I always like to think about it as just to summarize and to wrap up, is to think of the different layers of how we can reduce the risk. One, I think for most people, you know, who are eligible for vaccination, that's very important, because, you know, so keeping up to date with those more long-term infections, and also the annual vaccinations for things like flu, and now most likely that's where COVID will end up being, you know, more regular, almost either semi-annual or annual vaccinations. Then to think about whether there are these long-acting monoclonal antibodies that could perhaps help people reduce that risk further if they don't respond well to vaccines. While Evusheld is no longer an option, variants do change, and there are new options coming and being developed. So that could change again in the next 12 months or so. And then for a smaller group of patients who have these low antibody levels, then replacing it can also help. And then in the right situation and for the right time, then taking either antibiotic regularly or antiviral regularly could help. Again, not for everyone, but that could be helpful for certain select situations. And then the final thing is to always, I encourage all my patients to be vigilant for signs of infection. So not to ignore it, not to, you know, remain at home if they have fevers and shivering and shaking. Those are never good signs to stay at home for. And the key thing is that for a lot of these infections, we have early treatments for. And the key is recognizing them early, getting seen early, and getting treated early, which then helps to reduce the severity for infections as well. So with that, these are just some of where I think the field and infections in myeloma will go. But I think more importantly, perhaps we'll take questions from you guys. And thank you.
And you definitely touched on a lot of the topics that I know I personally encounter as a myeloma nurse in our groups and on the support line as well. So I've got a bunch of questions to ask you if you're happy to answer. The first one is about COVID, as you were talking about, and you can't avoid it in your presentation. So people with myeloma, should they still be isolating and staying home the way that they have done the past couple of years with COVID, or do you have a sort of a recommendation of when they can stop doing that?
Yeah, that's always a very tricky question to answer in a very simple sort of way. Yeah. I think in general, it depends on what phase of treatment that you're in. Obviously, as I touched on right at the start, there are different phases of treatment, and certainly some phases are more intensive than others and require a bit more immune recovery than others. So I don't think there's a sort of simple everyone sort of answer there. But certainly what I still encourage patients to do with COVID, but also other respiratory viruses, is especially indoor type activities always carry a higher risk. So it is a balance of course, living your life and being able to meet friends and family and being social. But I think, just to keep in mind that any indoor type activities, especially with lots of crowds, for any respiratory virus, including COVID, always carries a higher risk. So I would still encourage patients that if they're in that situation, to be careful and to mask up. But again, that's just a very broad recommendation. And I think for specific situations, especially when you're having intensive therapy, or if your disease is back and you're about to start intensive therapy, then I think, to avoid disruption to your care, and obviously as part of your recovery, you should always take advice from your clinical team about what sort of extra precautions that you might need to take.
Very well answered. While we stay on the topic of COVID, another question is regarding the injections Evusheld. So a lot of people have received this in the community, and there have been questions about whether another type of therapy like this will be available on the horizon or in the short term. Can you talk a bit about that?
Yeah, without sort of, without mentioning any specific products and things, I think one thing good about Evusheld is that it was effective when we were using it. But as we all know, because it's such a bespoke design, as it was targeted to certain strains of COVID, and of course, as strains change, unfortunately, it's not been effective. And that's sort of been the story with these antibody therapies for COVID, from the sort of the start of the pandemic. So, but to answer your question specifically, certainly people have found this approach to be helpful, this long-acting preventative approach, so not treatment, but prevention, have been found to be effective. So the companies, different companies are making new products, but they're all sort of in the evaluation phase in clinical trials. So there might be clinical trials, depending on where you are, of course, in Australia, there may be clinical trials looking at this question, or the next generation of something similar to Evusheld as a prevention. But I think, it'll be negligent of me to mention things because I think, they're being studied, and so we don't know if they'll be effective as yet. But certainly the approach of using these long-acting antibodies as prevention, certainly I think it's here to stay. It's about finding the right, more effective product.
Thank you. You also, as part of your talk, you were talking about the Shingrix vaccination, which you mentioned is not PBS listed, but there are people who are receiving it. And for the people that have received the full course of the Shingrix vaccination, do they still need to keep taking their antivirals like Valtrex or Valacyclovir?
Yeah, great question. The quick answer to that is no, but also depending on the situation. So I'll explain my answer there in two parts. So if, for example, if it's after a stem cell transplant and you've completed the 2 doses of Shingrix, then in that situation, you don't have to keep taking valacyclovir. But why I've qualified my answer is just because in different scenarios where people have had Shingrix, but then have had to go on to, let's say, another proteasome inhibitor, so more calcifimab or more bortezomib, then in that situation, we're not sure if Shingrix alone is enough to prevent shingles. So then in most, I think, clinical teams, they would be more cautious and still recommend people take Shingrix in that situation. So, but if it's after transplant and you've completed your course and let's say you're on Revlimid as a maintenance, then, you should be able to stop your valacyclovir.
Thank you. Is there a specific time frame that you need to wait between having different kinds of vaccines? So if you use Shingrix, for example, do you need to wait before you have another COVID booster, or is there any other sort of time frames that you could talk to?
Yeah, so look, in general, the vaccines themselves can be co-administered. So there are very few, of course, again, always check with your providers for specific vaccines, but in general, most of the vaccines can be co-administered without, needing a break between themselves. But as you can see from the previous slide I've shown, is that vaccine schedules are very complicated and they are all sort of scheduled in a certain way. So it's more important to maintain that schedule rather than sort of focus on, whether they can be given together. But if the schedules line up, like after stem cell transplant, we can certainly give, for example, we do up to 4 vaccines on the same sitting. So that shouldn't be a problem. It's just making sure that whatever vaccine you're having fits its schedule.
Thank you. You've done really well at answering some kind of curly questions that are often requiring a specific answer on a patient-to-patient basis, but you've done really well. So thank you very much.
No worries. I mean, I've tried to give as broad an advice. At least, of course, when it comes to your specific situation, it's always good to get a specific answer from your clinicians. And if they are not as certain, of course, they can seek additional advice from, I'm sure there's lots of equivalents of me across different teams. So I think it's always important to get specific advice if you're not sure.
Definitely. Thank you so much for giving your time this morning and for sharing so much with us and for answering those questions. Enjoy your day. Thank you, Ben.
All right. See ya.
We're going to continue on to our final speaker in our lineup today now. And her name is Dr. Veronica Johnson. And she is a clinical psychologist from Bacchus Marsh, Ballarat and Great Geelong Psychology Clinics, with over 20 years experience working in schools, hospitals and private practice settings. She adopts a compassionate, collaborative and engaging approach to therapy. This approach allows for a strong connection with her clients, emphasising a space of openness and trust. She works with her clients and their loved ones to assess the problems they are facing to implement individualised, evidence-based treatment plans that encourage her clients to live more fulfilling and meaningful lives. After a personal experience with loss, Veronica's passion grew for working with people in the midst of traumatic life events and those experiencing grief and loss. She has confidence and belief in an individual's capacity to find purpose in the midst of increased distress when faced with things they can't change. And we're so happy to have you here with us today, Veronica, talking about reducing the emotional stress of myeloma. So welcome.
Thank you. Thank you for having me.
And I'm going to hand over to you if you're happy to go ahead.
Yeah, absolutely. So thanks everyone for joining me. I think this is a little bit unnatural for me in terms of a presentation style, because I usually like to have people engaged and responding to me and sort of asking questions. So if any questions come up along the way and you want to ask them, please sort of send them in. And I will also leave my contact details for people that might want to do that at the end. But otherwise, it's just going to be me and my voice for the next little while. So I suppose, part of the things that I do want to talk about, though, I'd really encourage you to be reflecting on your own situations throughout it. So you might want to have a notepad or a pen and just sort of writing some things down, or, sort of putting the diagrams out for yourself, just to really bring in some and tie in some of the things that I'm talking about to your own personal situation. So I'd really like to talk to you today partly about the role that a psychologist can play as part of your care team. As well as some of the key things that can really play a major part in helping you reduce that emotional stress and psychological stress that is present throughout your journey. So the idea of the presentation and thinking about sort of reducing the emotional weight, I don't want to take away the emotions, like the idea that these difficult emotions are present, like they're present for a reason, and it's because we're dealing with something in our life that we can't change, and it's really uncomfortable. So we're not going to try to delete those emotions or take them away. We just sort of want to hold them a little more gently. And there's ways that we can relate to our emotions that give us, and our experience, that can really give us a chance to act differently and continue to live a life that's really purposeful and meaningful. So I'm going to focus on a few different areas today. I think that there's multiple areas that we could focus on, but with speaking with some people in the community last year, it seemed to be that these three things were really pertinent and related to people that I was talking with. So I thought I'd focus on these today. One of them is that mind-body connection that we can't escape. The other one is how to take some power back in a situation where you can feel particularly powerless, and also navigating that change of identity that comes about when we receive a diagnosis or when we're trying to manage like a chronic health condition. And lastly, I'll just sort of touch on how you can access mental health support if that's something that you're wanting to do following this. So firstly, if our body's under physical strain, then the presence of psychological stress is just inevitable. So we might feel a range of emotions: stress, anger, sadness, uncertainty, confusion, fear, overwhelm. And we might skip between these really quickly, and we might sit in some more comfortably than others. But ultimately, when our body is undergoing something or going through an experience that's really difficult, then the illness doesn't just sit there. It absolutely creates that stress and impacts our mind as well. What we know is that our brain is like, its number one job is to help us try and survive. So if we've got something that's threatening us in a physical sense, then our brain is not going to allow us to tap into the emotional side because it's just too much and it might overwhelm us. So what we often do is we'll disconnect our emotional experience from our physical experience. And it's sort of necessary, because when your body's undergoing that and you're trying in sort of survival mode, is we can't bring in all that emotion as well because it is too much. So we cut it off so we can survive physically. But it's sort of like holding a ball under the water. Now, normally I'd demonstrate this, so we'll see how I go on the screen. But if you sort of imagine yourself with like a beach ball or a basketball, and you're trying to hold it underneath the water. Now, most of us have done this in our lives where we're really trying to hold it down, and you're looking at the ball and you've got to struggle with it, and the ball's trying to come back up, and and the more that you're holding it down, the more it's trying to come back up, and it's slippery, and meanwhile, while you're just focusing so much on this ball, your family, your friends, people that you care about, it's all happening over there, but you just can't be in there because you're really struggling with this thing. And the minute that you stop focusing on it, the ball shoots up and it comes up to the top. And I actually had a client once, it was an adolescent client, and he said, well, when my ball comes up, like it hits my whole family in the face, like it really shoots back quite violently. So if we're starting to think about this holding the ball under the water, like our own difficult feelings, you know, if our brain's going to shut off our emotions from our body, except just like holding the ball under the water, at some point, those emotions are going to come back to the surface. And sometimes it's when we least expect it. And sometimes it comes back quite powerfully and, you know, hits our whole family in the face as such. While we're in that moment trying to survive, you know, as I said, it can become necessary. But what we want to do in time is we want to just let the ball float on the surface. You know, it means that we can see it. It means that it's sort of uncomfortable, and it might even sort of knock into us, and it's really present. But we can choose to look towards it, and we can also choose to move away from it. And we can also choose to go and engage with our family, with our friends that are over there doing the things that's really meaningful and important to us. So if we can continue to sort of think about our feelings in that space, that even though they're not front of mind, even though we might have this disconnect, is that they're still there, and they're very present, and they're still impacting us. And, you know, with that, we can't necessarily go around them. We have to go through them at some point. So how do we do that without them becoming completely overwhelming to the point that we sort of lose focus of what is important to us? Okay. Just going to flick through to the next stage. If you've got any questions, so please ask them and we can come back to them at the end. One of the things that becomes really apparent in any situation where something in our life's happening and we can't change it. We're not in control of it. And it doesn't matter what we do and what we try, we actually can't change this thing that is changing our life. It leaves us feeling really powerless. You know, and in terms of your journey, I'm sure there are many aspects of treatment, many aspects of the progression of your illness that just leave you feeling powerless. And feeling powerless is a really, really challenging place to be. When our mind and body try to block out our experience of things, like we were talking about in the last slide, and when we feel like we have no power, our brains go into that problem-solving mode and they search for a solution. They try to find everything they can to fix this problem. So what's going on here? I need to fix it. Something has to change because I'm not okay. You know, our brain protects us. If I'm cold right now, my brain says, go and shut the door. If I'm hungry, my brain says, go and eat. If my computer is broken, it says, go and contact the repairman. It's got a solution for everything. But what about when we don't have a solution to the problem? Our brain, we try to start to control everything. And not only everything that's related to the problem. So some things that we try and control might be quite helpful to us. We might try and control our diet. We might try and control having some semblance of routine. We might try and control some of the treatment that we choose to engage in, the recommended activity that we do. But when we start to try to control things that aren't related to the problem, it can become quite unhelpful. And also trying to control things that we actually don't have any control over. We might try to control the people around us, what they do, how they feel, their reactions to things. We might try and control the way that we feel and control the times that we feel. We might try and control the things that happen to us. It's sort of useful, you know, it can be useful to tap into this area and think, well, what can I do right now? But if we get stuck in this space, it can be really unhelpful. So there's merit in taking power back when we feel completely powerless, but not in trying to control everything, because there's so many things that we can't control. You know, think about the weather, for instance, or the fact that there's a global pandemic. Like, there are always things that we can't control. So we have to sort of decide, where do we want to focus our energy? And particularly if we're sort of feeling lower in energy and lower in motivation, we want to make sure that we're pinpointing the things that where we're going to get like the most bang for our buck, I suppose, the things that are going to really bring about sustained change. So here's where I'd normally have you with a pen and paper and thinking about your own situation. And this is something that we call the circle of control. So in the middle of the diagram here, and if you wanted to do it for yourself, I would really encourage you to. So I'll sort of talk through this slowly in case there is anyone that wants to have a go at this, or even if you take this away and sort of think about it more from your own point of view, or even you and your loved ones around what are things you can control and what are things that you can't. We've got the circle in the middle here, and this sort of represents the things that are actually within your control. So some of the things that I thought of is, well, you can control what you eat. You know, you can choose what food you make, what you choose to consume. You can also choose what information you consume, because I know like we alluded to my experience in the intro, but I know when I was sort of in hospital and dealing with this huge big thing that I couldn't change, is the nurses used to joke that I was getting my doctorate in it, because I would just sit up and just read and read and read and read and read. But we need to be really careful about how much information we consume and what information we consume. How you communicate with other people, the words you choose to use, where you communicate, what you communicate, how you spend your time and who you spend your time with, where you choose to focus your attention, who you have within your care team. All of those things are absolutely within your control. Now, outside of the circle, there's some things here that we can't control, but definitely play on our mind and definitely try to pull our attention away. The changes that happen to our body, the fact that we have an illness, changes to our libido, changes to our physical appearance, other people's behaviors, your capacity to do the things that you used to do or the things that are important to you, other people's reactions, any sort of treatment outcomes, the toxicity of the medication, other people's feelings. We want to check in outside of the circle, but if we get stuck out there, it can really cause us that increased distress. And what I would almost imagine you doing is, it's like if you notice there's high distress in your life at this point, just consider if you're maybe stuck outside of this circle, stuck focusing your attention on all of these things that are actually outside of your control. Because at any minute, you can actually choose to step back into that circle in the middle. And sometimes it's even useful to do it, like actually go, I'm going to step outside of this space because things are unsettling. So and focus again on what else I can control and spend my time there. These are sort of generic things I want you to think in your life, like what else could you maybe add to this? On either what you can control or what you can't control. something that that's really striking to me is, and probably not something that we overtly focus on or think about in our life, is who we are, how we see ourselves. And I think when we're faced with something in our life that's life-changing, is we might not realize just the impact that it has to that stable idea of who we are. And when we have to integrate an illness into that identity, it's a huge process. And it takes time, and it takes a lot of self-care and compassion, and it takes a lot of patience. Before a diagnosis, if you think about what might you have identified as in your life, it might have been wrapped up in what you did for work, in certain hobbies that you might have been engaged in, a role that you played in the family, maybe being a certain type of friend or having a certain personality. The way we view ourselves actually influences how we interact with other people and how we interact in the world around us. Now, some of those ways of viewing yourself and your identity, they might hold true, and you might still feel like that person. But some of them might not. And some of them might be completely thrown into turmoil after a diagnosis or during your treatment journey. So if your view of yourself changes, how do you now interact with the world around you as this person? Changes your relationship dynamics. Maybe it might change your work. It might change your capacity to engage in things that you've previously done. And that can really leave you feeling very alone and very lost. If we think about that connection to ourself and our self-identity and our self-worth as being something that keeps us quite stable, you know, when there's like this emotional storm sort of around us, it's like our anchor's dropped, because we know who we are and how we manage these situations. If your identity is not on that stable space, and there's lots of change and and you're feeling quite unsure, unsettled, quite on edge with that, or fragile, and it's going to change your ability to engage in the world around you and with people. And that's okay. But I think it's something that we struggle a lot with. We struggle a lot with that change. So what do we do about it? We need to try and connect with others with similar journeys. Share our story. Maybe work closely with a professional to continue finding your purpose. Finding purpose in the midst of this constant change and uncertainty. And when you find your purpose and you find what's important to you, because there's always things that are important to us. They might be different to what they were a month ago, a year ago, 5 years ago. But when we keep connected to what's important to us and what brings us meaning and purpose in our lives, then we can feel more grounded, we can feel less alone, and we can sort of make sense of things a little better. The real power lies in understanding how we can live with something that you can't actually change, but continue to find purpose and meaning in your life. At this point, a lot of my clients might say to me, I have no idea what's important to me. Like, I don't know what that is. There's lots of different things that you can use to sort of think this through. You know, you can think of sort of role models or the things in your day where you feel the most connected. But there are also tools online that you can use as well. And I'm not sure how we get this to people, but this is quite a good one. It's just like a card sort where you can just go into it, And you have a look at each one and you basically say, is this very important to me? Is this not important to me at all? Or is this a bit important to me? And you move things along and you think about, and it really gives you a sense of reflective space around, is support important to me? Is knowledge important to me? And it just helps you think about what might be, I guess, things that you really want to focus on and bring into your world as much as possible at that time. So it can help us have a sort of a connecting point and help rediscover who we are a bit at the moment. So, we're really just scratching at the surface here of, little tidbits of information for you to take away, and hopefully something has resonated. Hopefully something feels like it's useful. But what you can do is, like psychologists, counselors, any sort of mental health clinicians can help in this space. They can help with those difficult emotions that arise. They can help us sort of bring together that mind-body connection and allow both experiences to be there together. They can help understand change to your identity. We didn't really touch on it, but effectively communicating with loved ones and sort of noticing what you might be trying to control in each other and for each other, and how to talk about things, what words, what language to use, things that you might be avoiding within those communication channels. And lastly, they can really help you connect with what's valuable in your life, what's important to you, and making sure that becomes a focus point while you're dealing with something that you can't change. We've already mentioned our clinics. There's Bacchus Marsh, Greater Geelong and Ballarat that we've got clinicians at that can help if people want one-to-one support. We have telehealth sessions as well. To be able to access support, you don't have to do anything. You can just call up. You can just pop an inquiry in through the websites, but you can also go to your GP and get a chronic disease management plan, and that actually gives you access to some Medicare subsidised sessions. So if you're feeling like that's something you want to do, you can talk to your care team about that. And I think that's where I'm going to leave it and see if there's any questions.
It was really interesting, and I really appreciated your delivery, giving people in the community the chance to really consider and think about some of the things that you were talking about, specifically the circle of control, which I think is so important and something that that people in our community could really make use of. With myeloma, it can be something that, and we hope that people will live for a very long time with it. And so with the ebbs and flows that can come with being on treatment or being on maintenance, there are periods of time where you are feeling that distress, and then times when you're not as much, but having something that sort of triggers you to remember about the circle of control and the things that you can control and the things that you can't. It's really useful.
It's I think the language that we use is really important too, because we can often find ourselves, and our brain will always do this, is takes us to what we can't do. I can't do that. I can't do that. And a shift in, okay, that might be the case right now, but what can you do? And we can start to focus on, well, I can do this, I can do that. So I can have myeloma and still I can be undergoing treatment and still. Yeah, definitely.
The other thing that a lot of people living with myeloma have as a situation is that they're often on steroid therapy, which keeps them awake, and often they will spend many late nights lying in bed awake, full of distress, worrying, unable to calm down. Could you just, off the top of your head, come up with any or offer some strategies that could help people that are living with that at the moment?
Yeah, absolutely. And the night times are the hardest times because You know, we don't have the distractions of the world during the day, so we often have our own thoughts. And I guess right now we have access to information as well on our phones. And when I was mentioning before is that I would absolutely be up all night just delving into the, you know, down rabbit holes that are scientific articles about what I was managing, trying to find answers. I think that whenever we find ourselves very much caught up in our thoughts, and caught up in that space of our brains becoming problem solvers, is we have to try and then come back into our body. And so we, funnily enough, we call it sort of like dropping anchor techniques, so we can steady ourselves. And sometimes when things feel like they're the biggest, we search for big answers. And it's often when the smallest things become the most important. So that like one long, slow breath. Or even, I know, like sometimes I just like hug a pillow and sort of have that, you know, where you actually tense your muscles up and really hug the pillow and then, you know, and let it out. So those sort of techniques, sometimes things like some white noise. So having some sleep music on that just means that our brain sort of goes into a different space and has that on in the background, or some people put podcasts on or things like that. That can all be really useful. I guess the other part of sleep is sort of recognizing it's really normal for our sleep to be disturbed sometimes when there's certain medications and things. And if we fight against it all the time, then we end up pairing bed with distress and discomfort. And so I would say if you're sort of awake for more than like 20 minutes, we'd actually just recommend sort of hopping up, doing some light stretching or a little bit of reading until you're sleepy again, and then turning the light back off.
Great tips. It's really good.
Yeah, there's some cool, if you go actually on our website, there's in the resources section, any of the clinic websites, there's a sleep article there. And it gives some really great tips on sort of sleep hygiene type things that can be useful. So try all of those. But if you find that those things aren't working, it might be worthwhile sort of talking to the medical team as well around anything else that they suggest.
Yeah, that's great. And I probably just mentioned that if you're happy, I'm happy to share through our email service the links to your site from today, and also those value cards that you mentioned as well. We can share that link to anybody who's interested. So you can just email the nurse's inbox, and I'll give you those details at the end. We are right on time, but I did want to ask one more question that's come in from one of our viewers today, and her name's Donna, and she wants to ask, I think, a really important question, which is it important to always stay positive in front of children?
Yeah, it's such a huge question, and my background's in teaching, and I do a lot of child psychology, so I feel reasonably equipped to answer this. So thank you for asking me something, Donna, that I feel like's within my wheelhouse. Mm-hmm. I think talking to children about things is particularly difficult, and probably something that I would suggest most adults try and avoid. We find it really, really hard to see people we love in distress and upset. So we'll often try to not talk to the children, not show distress, not show sadness. It differs developmentally, because we're talking about, obviously, when we talk about children, we could be talking about, you know, sort of 2, 3, 4-year-olds right up to sort of 17, 18-year-olds. So I don't know if there's just generic advice that I can give. It also would depend on the child's ability to cognitively understand what's going on. If you've got younger children that understand that something's happening, they can often cognitively process something before they can emotionally process it. And so our job becomes to help them with the emotion processing of it, because otherwise they sit with high anxiety. And you'll see, and they can show that through like big behaviors like anger, upset, but they can also show it just by becoming withdrawn and avoiding things themselves and becoming more anxious. In terms of staying positive, I like to suggest to stay real. And, you know, there's nobody in the history of the world that's managed to only have happiness and joy and all the good emotions in their life and avoid all the difficult things. So I think it's absolutely okay to be real. And if you are feeling sad, if you are feeling worried about something, it's all right to own that and to model that, because what you probably will find is that the child's probably feeling that too and doesn't know how to express it. And so there's some really cool things on emotion coaching. The Gottman Institute do one, and it's really about, you know, if we sort of have to normalize the feeling. So we might say, gee, I'm feeling really sad today. Today's feeling like a bit of a hard day. And I'm noticing that, you know, I'm not really wanting to do much because I'm feeling really sad. Do you ever have days like that where you feel like that? So sort of really acknowledging and normalizing the feeling, and saying, and then validating it. It's okay. It's okay that we all have days like this. Can we work it out together, what we might do? You know, I'm feeling a bit sad. Maybe we might go and sit outside and have some, you know, get some fresh air and sit under the tree, or maybe we might take the dog for a walk. That might make us feel a bit better. Put something on the TV. So look up emotion coaching. If you want to send me an email, even because it is a really hard question to answer. Like if we're talking about a 5-6-year-old compared to a 13-14-year-old, we will deal with it differently, but developmentally appropriate language. Don't feel like you always have to be positive. Be real. I think we don't give them enough. I don't think we don't give kids enough credit for what they can actually manage. And we certainly don't want to feed into their avoidance of difficult feelings, because that's holding their ball under the water for them.
Yeah, you really are, as a parent, modeling behaviors that are acceptable. And so you're absolutely right. And it does need to be age appropriate too. So it is hard to speak to that question, because children change so much from being really little to being teenagers and into adults.
Yeah. The other thing I would tie back into is that I think when we try and predict how someone else is going to respond, then we're actually trying to control other people around us. And so, you know, we can obviously influence other people around us by thinking about good times to talk about things, how we talk about things, how we respond after we do. But, you know, space for questions, space for those emotions, space for talking about it and validating is always the way to go.
Yeah, absolutely true. I'm sad to say that we've run out of time, and I feel like I could probably ask you questions all afternoon.
That's okay.
I wanted to just say thank you so much for giving your time today and coming and speaking about something that is, I think, really, really important in the myeloma community. So thank you very much.
That's okay. Thanks so much for having me. And yeah, if there are any other questions like that, I'm more than happy to continue to answer them or send some resources through if you need for you to disseminate.
Fantastic. Thank you. Thanks for that.
That's okay. Thanks for having me.
Have a great day.
Bye.
Thank you. So now a little bit about our Multiple Faces of Myeloma campaign. We started this campaign late last year, where we asked you, the myeloma community, to submit your stories and hopes for 2023 and share with us what more services, research and treatment, as well as more nurses, could mean to you. You can still join this campaign and share your story with us, and we would love you to do that. You can do it via our website. The more faces and the more voices we have, the more we can improve the lives of Australians with myeloma. We've put together a slideshow of some of them today, so I would love you to sit back and enjoy some of our multiple faces of myeloma. Well, that concludes our seminar program for today. We hope you found the sessions informative. You are, of course, still very welcome to send through any questions that you may have arising out of the session today. You can send them through to our nurses email, which is nurses@myeloma.org.au, or you can call through to speak to our telephone support line on 1800 693 566, and you can speak to one of our amazing myeloma support nurses. And as Deborah mentioned, we really want to hear your feedback about this seminar and all of our Myeloma Month seminars. So if you have a minute to complete our feedback survey, please click on the link below the video on this webpage. Finally, I just want to give you a reminder to mark your calendars and join us for our third and final seminar, which will be streamed live from this website on this webpage on Thursday, the 30th of March, 2023. It will be screened at the same time, so 12 p.m. Australian Eastern Daylight Savings Time, and that's 9 a.m. for those of you in the same part of the world as me here in Perth. And before we sign off, I would like to give heartfelt thanks to all of our presenters today for their insights and knowledge, and to the organising team for this seminar series at Myeloma Australia. You've pulled together an amazing program, and it's going to be even better next week, I'm sure. Thank you also to all of our sponsors. And last but not least, a massive thanks to Darren and the whole team at CDP for their skillful production of today's event and our whole Myeloma Month seminar series. I hope you all have a wonderful day from wherever you're watching, and thanks so much for joining us.